What's up, beautiful people? Welcome back to another sit down video. It's me, Kendra. Let's go ahead and jump into it because for the longest, I've been meaning to do a video talking about things that I like to do at the beginning of my shift as an ICU nurse, or things that I like to double check at the start of the shift. Because I'm the kind of nurse, and I know this might seem negative, but whenever I go to work, I never see the glass half full. I always see the glass half empty. I'm always preparing myself like something is going to happen today and you need to get ready, stay ready, so you don't have to get ready is what I wanted to say actually. One of the first things I check for after getting report is who is my respiratory therapist for the day. Of course, working on the ICU, I might have patients who have compromised airways, patients who are intubated on a ventilator, or patients who have been recently extubated, possibly might need reintubation, patients who have tracheostomies, brand new trachs that was just placed. I need to know who my respiratory therapy is, because if in fact something is going on respiratory wise where a patient's oxygen is dropping low, or the patient appears to be working hard, or the patient is not really being synchronized with the ventilator, I need to know who my respiratory therapy is, so that way I can call on them in my time of need, in my time of doom, with any struggles that I have. Respiratory, who are you? Because I might need you, and you are one of my greatest allies working at the bedside. The second thing I like to check for once I assume care of the patient is suction setup. I cannot tell you how many times as a new nurse, especially when I worked on med-surg, whenever we would have a code and, the team will come to the bedside, the first thing anesthesia is looking for is suction. This is in case the patient has to be intubated or the patient's airway is compromised. They're always asking for suction. And so many times I have seen nurses scramble, running out of the room to go to the supply room to get suction because they did not have suction set up in the room. I always have my suction set up. If you're the kind of person where you might not want to set it up, it's important to at least have the supplies in the room just in case. So having your suction set up is very important. The third thing I like to look for whenever I start my shift, if my patients are on any type of IV medications, not necessarily antibiotics, but urgent or very important medications, such as pressors. Those are the medications that help keep the blood pressure up. Pain medicine, which can be used for sedation. So at times when we have the patient sedated, it's not uncommon for us to use certain drugs, fentanyl being one of the most common ones. And yes, fentanyl is safe if used properly in a healthcare setting, with orders from a physician, with a competent nurse following those orders. It is very safe. I like to make sure that I have enough medication in my IV bags. And if I find that they are running low, I like to make sure that the drug is either stocked in our med bin, or if I have to call pharmacy, I'm calling pharmacy, or I'm putting in a med request via the electronic system. Like, hey, can you prepare a next bag for me? Because I hate to be the person where the drip runs out and you're scrambling trying to find a new drip. So I always like to make sure that I have enough backup when it comes down to my IV infusions. One of the other things I like to check for, which I think is number 4 now, is IV access. It is one of the first pieces of assessment I tend to do when I assume care of the patient. Oftentimes in report, you will get that, the patient has 2 peripheral IVs and that's their only IV access, and you go to flush it and it doesn't work. I always like to make sure that my patients have a patent, working, very strong, it's a good IV, I can pull blood back from it, or even if I can't pull blood back, I need to be able to flush it, because just in case something were to happen, like an emergency with that patient, having good IV access is very necessary. Luckily, working in the intensive care unit, a lot of times our patients will have what we call central lines, which is a temporary access that is usually placed by the provider. So that way we don't have to worry about having these peripheral IVs, which can go bad very quickly depending on your patient's vasculature. But it's always important. I can't stress enough to always check to make sure that you have a good working IV. Of course, another piece that is very important is knowing your patient's code status. And I probably should have put this as number one, but during report, we usually get whether or not the patient is a full code, meaning that we are going to attempt every form of resuscitation. If in fact the patient cardiac arrests or respiratory arrest, we're going to do whatever it takes. But you do have some patients that have legal paperwork in place stating their wishes. Some patients do not want any resuscitation efforts. Some patient might want to be resuscitated, but they do not want to be intubated, meaning that they do not want to be placed on a respirator. Or some patients are just do not resuscitate, do not intubate. If in fact it's my time to go, it's my time to go. It is very crucial to know that, because you don't ever want to not honor your patient's wishes. So always know your patient's code status. I probably should have mentioned this when I talked about the IV medications, ensuring that we have enough in stock, or ensuring that pharmacy will deliver us just in case those mini bags run out. But as a nurse assuming care of the patient, the first thing in the morning I double check as well is that the really serious medications, which all medications are serious, right? Because medications can adversely affect patients differently depending on what allergies or depending on what illnesses they have going on. So it's always important to double check not only just the fluids that's hanging, but I always make sure and double check my rates. So for example, if my patient is on Levophed is one of those medications that we use to help keep the patient's blood pressure up. If the nurse gives me a report and she was like, Levo is running at 8 mics per, how does it run? 8 mics per hour? I can't, don't quote me guys, okay? I forgot, I'm off. But anyway, if she gives me a rate of like, if she gives me a dosing of like 8 mics, I want to double check the pump to make sure that it is running at the 8 mics. And I also want to double check the parameters so that way I can see and make sure that it's even converted into the right conversion in the pump, because sometimes some institutions might run it by mics per hour or mics per keg per minute. So it just really depends. Always just double check the medications that's running against the physician's orders and against the institution's parameters, because different institutions might have different parameters. Like you could work at one hospital and they're okay with propofol max at 70, and you go to another institution and propofol should be maxed only at 50. So just always double check. Never take the off-going nurse's word for everything. Go ahead and do your double check. Now, this one is a little bit odd, but this happened to me years ago. Not necessarily to me, but I had came on shift. I wasn't working in the ICU at this time. I was working on an IMC, which is pretty much like a step-down ICU. I came on shift and I had a patient that had a really bad pressure ulcer, really awful pressure ulcer. And when I walked into the room, the wound nurse was walking in with me at the same time. And she looked at the bed and she was like, the bed is not plugged in. And I was like, oh, it's not? And she was like, yeah. She was like, when did this happen? I said, I don't know. It's 7:37. I just assumed care of the patient. I'm coming in the room the same time as you. And she ended up writing up the previous nurse. She reported it because the patient had a pressure ulcer. The patient was on a specialty bed. So the mattress is basically doing a lot of therapeutic movements to help assist with the wound not getting any worse. I don't think that wound was going to get any better, but the mattress is basically considered a form of like, it's an order. It's almost like ordering a medication that was put in for this patient to have. And I don't know what happened on night shift, but they shut the bed off or they unplugged it. I don't know if it wasn't working or if it was just like annoying them because it was beeping, but they did plug it out. The wound nurse caught it. And thankfully I had just came on shift, but I always check whether or not my patient's beds are plugged in. Listen, I don't want any problems. I don't want anything on my record saying that because of me, the patient acquired a pressure ulcer. So I always double check my beds to make sure that they're working, especially if it's a bed that's specifically ordered to provide therapy for wounds. I always double check to make sure this bed is functioning and it's working. Another thing I like to double check, and I specifically go through my orders, is if my patient has any tubes inserted. So for example, if my patient has an NG tube, which is a tube that we advance into the stomach just in case we need to give medication or we need to give supplemental feed into a patient because they have a compromised airway or they're not safe to swallow. But other times too, we will insert an NG tube if the patient is having like GI issues and we need to decompress the stomach. I always double check orders to make sure that the connection is correct. So for example, some doctors might order the tube to be connected to low intermittent suction or low continuous suction. And sometimes some surgeons will give a very specific number of how much suction they want the patient connected to. So I always like to double check, because let me tell you something, I don't like embarrassment. I don't like embarrassment. And especially if you're taking care of surgical patients, surgeons, I hate to say it, a lot of surgeons are just crazy, okay? They will while out for any given reason, anything that they don't think is right. A lot of them will just while out and go crazy and start yelling, da 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 da. And yeah, I can't do the embarrassment. If my patient has nephrostomy tubes in because they were placed for whatever renal issue is going on with the patient, I like to double check orders. Am I supposed to flush these tubes? How often am I supposed to flush it? What am I supposed to flush it with? So those are things that are very important to me that I like to double check and know at the start of my shift. And last but not least, whenever I assume care of my patients, I never want to assume that they're comfortable. So one of the things I always do initially, assess neuro status. Get a baseline neuro status. I've talked about this, I think, endlessly in previous videos, how important it is to establish a neuro baseline for your patients, because you're just coming on. You got rapport. The off-going nurse might have told you that this patient is alert and oriented times 4. It is important for you to do a quick neuro assessment to establish a baseline. And with that neuro assessment, another thing I like to do is ensure my patient's comfort. So the first thing when I go into my patient's room, after I do all my quick checks, make sure my medications are okay, I check my patients. I want to know about pain. Are you having any pain? Because if you are, let's take care of it right now. If there's nothing available in the PRN section of your meds for me to give to you, let me go ahead and contact the physician so we can get something ordered for pain. I also like to double check whether or not my patient has to go to the bathroom. So I offer, if they can ambulate, which 9 times out of 10, I'm on an ICU, they don't ambulate, but I'll pull the covers back, I'll lift the gown up to make sure that my patient is dry, because not every patient that's in the ICU have a Foley catheter. We like to get Foley catheters out as quick as possible to prevent infection, but I always double check my patients to make sure that they are dry and to make sure that there is no bowel movement, because I would hate to come on shift, not check, go about my daily business, pulling meds, doing this, and my patients are sitting there uncomfortable. So those are the things I always check. Go ahead, if you're a nurse working at the bedside, drop some comments. Let me know what are some things you prioritize and check in when you start your shift. And I will see you all in another sit down video. Thank you for watching.